Hello everyone, I am Dr. Asmatullah and today we will discuss section 1 cataract from provision ophthalmology MCQs 5. Question number 1. A 72 years old woman has function limiting visual blurring in the right eye. Her visual acuity in the right eye is 20 by 200, varying -1.7 spherical correction. Manifest refraction improves her visual acuity to 20 by 50 with a correction of -4 spherical refraction. Given her findings shown, what refractive management would you recommend? Okay, this is a case of a brunescent cataract. This figure shows a moderately brunescent nuclear sclerotic cataract. Given her refraction, the preferred next step would be to consent the patient for cataract surgery. LASIK is not an appropriate in this situation, for it would not provide vision correction. While diabetes is associated with this type of cataract, addressing this area would not address her visual needs or her rehabilitations. In cases with milder cataract, the clinician can ask how the patient is currently doing with activities of daily living, and it can be discussed how much improvement a new spectacle prescription or a contact lens use could provide. So, in this case of more significant cataract, neither contact lenses nor glasses will provide enough visual improvement. Thus, the cataract surgery is the better choice, except in the case of a medical need to remove a cataract like phacomorphic or phacolytic glaucoma. It is usually preferable to listen to the patient's needs and consider how the patient's vision is affecting his or her lifestyle. So, the correct option in this MCQ is cataract surgery with IOL implantation, which is option C. Thank you so much. Now we will go to the next option. The next MCQs. What finding is confirmatory for post-cataract cystoid macular edema? Okay, fair enough. So, cystoid macular edema basically is a common cause of decreased vision after both complicated and uncomplicated cataract surgery. The most dependable, sensitive, and specific finding to confirm the diagnosis is the development of petalide hyperfluorescent pattern on fluorescein angiography. So, CME or cystoid macular edema may be suspected from an otherwise unexplained reduction in the visual acuity in the late postoperative period and may be seen on biomicroscopic examination. So, the sensitivity of OCT is very sensitive but is not specific for postoperative CME. The incidence of both angiographic and clinical CME peaks between 3 to 10 weeks after surgery. This is important. The peak of CME is 3 to 10 weeks after surgery. Spontaneous resolution occurs in approximately 95% of uncomplicated cases, usually within 6 months. Treatment for CME by topical non-steroidal anti-inflammatory drugs and steroidal eye drops may be effective in some but not all cases. So, the correct option in this case is petalide hyperfluorescent pattern on fluorescein angiography. So, the option B is most preferable option. Now we will go towards the question number 3. On the first post-operative day after phacoemulsification and posterior chamber IOL implantation, a 67-year-old man develops diffuse corneal edema as shown in the figure. The entire central and peripheral cornea are equally affected. So, the unoperated cornea is normal, he has no pain, and his IOP is 17 mm of mercury. What is the most likely cause of this edema? So, the options are given below. Let me check. Okay. Basically, corneal edema may occur in the immediate postoperative period for a number of reasons. But in this case, which is shown in our question, the diffuse decompensation is most likely due to the infusion solution. Onset of corneal edema is higher in eyes with pre-existing corneal dysfunction, such as Fuchs dystrophy, but this patient has no evidence of having this bilateral disorder as the other eye is described as normal. Edema may be caused by a combination of mechanical trauma, prolonged surgery, inflammation, and elevated intraocular pressure, which will result in acute endothelial decompensation with an increase in the corneal thickness. But a combination option is not provided. So, toxic substances introduced into the anterior chamber can also cause acute endothelial decompensation. So, a descent detachment would be visible and would cause a focal area of stromal swelling and epithelial bully in the area of detachment. Anterior chamber collapse with IOL endothelial touch is usually painful and usually the eye is not normotensive in that case. So, the best option is response to intraoperative intraocular solutions. This is basically a case of TOS, toxic anterior chamber syndrome. Okay. So this was question number 3. Now we will go to the question number 4. In the case of a mature white cataract, what additional consideration would you advise regarding capsulorhexis? Okay. Basically, capsulorhexis is more difficult when the red reflex is blocked by a white mature cataract, making the use of capsular dyes of a greater advisability. The capsulorhexis needs not be larger in these cases, and either a cystitome or a forceps are both good choices. A continuous curvilinear capsulorhexis is a preferred choice over other methods since each point of capsular puncture has the potential for a radial tear if stressed. So, the most preferred response in this case is use of a capsular dye would facilitate capsulorhexis, which is trypan blue dye. Question number 5. When comparing subtenon anesthesia to retrobulbar anesthesia for ocular surgery, what is the most advantageous characteristic for subtenon anesthesia? Okay. Retrobulbar anesthesia has a significantly higher risk of globe penetration when compared to subtenon or peribulbar injections. In peribulbar anesthesia, a cannula or a shorter needle is used than the retrobulbar anesthesia. Anesthetic solution is introduced external to the muscle cone underneath tenon capsule by single or multiple injection sites. Theoretically, peribulbar anesthesia eliminates the risk of complications such as optic nerve injury and central nervous system spread of anesthesia from the intradural injection. The risk of globe penetration is less, though not eliminated. The peribulbar method is less effective than the retrobulbar for providing akinesia and anesthesia. In addition, the onset of effect is slower. One is not assured complete akinesia with peribulbar anesthesia. Posterior anesthesia is not the goal in cataract surgery. The possibility of adhesions would make the use of periocular anesthesia in the setting of a prior ocular surgery suboptimal. So, the correct option is lower risk of penetrating injury into the globe. Okay. Now we will move toward the question number 6. During the performance of cataract extraction with IOL implantation, what are indications for use of an adjunctive capsular tension ring? The picture shown in figure is capsular tension ring. Okay, so let me show the options. These are the options. A common indication for capsular tension ring are cases in which zonular support is compromised or in question. Such cases include exfoliation syndrome, trauma, congenital and developmental disorders such as Marfan syndrome, and inborn errors of metabolism. Use of a CTR is contraindicated in case of an anterior or posterior capsular tear. Posterior polar cataract does not have zonular weakness, and neither do cases of vitreous hemorrhage. So the best option is option A, Marfan syndrome, Weil-Marchesani syndrome, and pseudo-exfoliation syndrome. So now we will move toward the question number 7. During cataract extraction, you perform a continuous curvilinear capsular access. After subsequent hydrodissection, you notice interior movement of the entire iris lens diaphragm and collapse of the interior chamber. The IOP is high and the patient is not experiencing any significant pain. Placement of viscoelastic gel does not reform the interior chamber. What is the most likely cause of this phenomena? In rare cases, the fluid infused into the interior chamber may be misdirected into the vitreous cavity, causing an increase in the vitreous volume with subsequent forward displacement of the lens and shallowing of the interior chamber. The fluid may accumulate in the retrolenticular space or dissect posteriorly along the vitreoretinal interface. This complication, called posterior infusion syndrome, which is most likely to occur during hydrodissection when fluid is forcefully injected into the capsular bag. A shallow interior chamber resulting from posterior infusion syndrome may indicate loss of integrity of the capsular bag. As to the other choices, choroidal hemorrhage is typically painful. An empty infusion bottle would not apply in this situation, as the case had not yet proceeded to the phacoemulsification or irrigation aspiration. A Valsalva maneuver may cause posterior pressure in the eye but not cause a higher pressure. So the best option is posterior infusion syndrome. Now the question number 8. During cataract surgery, you create a temporal clear corneal grooved incision with 2.5 mm keratome. The tunneled incision is 2.5 mm long from the epithelium to descending membrane. Following capsular access, hydrodissection, introduction of phacoemulsification needle, and commencement of infusion, multiple corneal stria are noted to emanate from the wound. What is the most likely cause? Okay. One disadvantage of clear corneal surgery include potential intraoperative development of corneal stria when the incision extends too far from the limbus. The resulting complications include decreased visualization or predisposition to corneal thermal burns. For this patient, the elongated tunnel in a clear corneal wound produces stria with minimal deviation of the phacoemulsification needle from the wound axis. Vacuum aspiration rate and bottle height do not cause or exaggerate corneal stria. So the preferred option is tight tunnel incision. Question number 9. So this is question number 9. 30-year-old schizophrenic patient has non-seasonal periocular dermatitis and keratoconjunctivitis which is treated with ocular corticosteroids. What association explains the patient disorder for the abnormality shown? So we have four options over here. This is basically a case of atopic dermatitis. Atopic dermatitis is a chronic pruritic erythematous dermatitis that may be associated with anterior subcapsular cataracts, which this patient has. Okay, so the correct option is A, atopic dermatitis. While myotonic dystrophy will cause Christmas tree cataract, phenothiazine toxicity will cause bilateral cataract. Okay, while the third one. Okay, now question number 10. So what operative factor contribute to the microscope induced light toxicity during ocular surgery? So we have four options over here. Longer operating times contribute to photic injury to the macula, to the retina. Microscopic filters and tilting the microscope reduces the risk of photic injury. It has not been shown or claimed that the use of viscoelastics significantly reduces the photic injury. Prolonged exposure to illuminating filament of the operating microscope can result in an increased risk of cystoid macular edema or a burn to the retinal pigment epithelium. The risk of an RPE burn is particularly high during cataract surgery. When the light absorbing effects of the natural lens cataracts are removed, this maneuver exposes the RPE to minimally attenuated blue and near ultraviolet radiation. If the photic injury occurs in or adjacent to the fovea, visual acuity may be reduced. If the injury is extrafoveal, the patient may develop a paracentral scotoma. Minimizing retinal exposure to the operating microscope light and having as short as possible operating times help reduce this complication. Other actions to reduce the risk of retinal photic injury include using the minimum light intensity needed to safely perform the procedure. Always use manufacturer approved lamps using a filter to attenuate wavelength below 515 nanometer. Using oblique lighting when possible, using pupillary shields and minimizing direct exposure of the fovea. Thank you very much. Tomorrow. So the correct option is long operating time. Okay. Tomorrow we will discuss the remaining question. Thank you so much.